Welcome, Dr. Khan.
Thank you so much for the kind words, Dr. Rodriguez, and for the introduction. So we'll start off with our presentation. So we're presenting about skin and soft tissue infections. So we'll delve right into it. All right, so I do not have any disclosures to begin with. So we'll start off with the objectives of today's talk. So we're going to go over the various kinds of skin and soft tissue infections that one may encounter in medical practice. We'll try to recognize their presentation, identify what causes these infections, and then also outline treatment modalities for this. Before we go into the details of each kind of infection, I think it's important to have a basic idea of the structure of skin and soft tissues. So on this slide, you will see that there is a transaction essentially of the skin and soft tissue, starting from superficial up top to the deepest tissue at the bottom of your slide. So the skin structures are basically starting from up top so with the epidermis, then we followed by the dermis, followed by the superficial fascia, deep to which is subcutaneous tissue, and subsequently deeper to that is the deeper fascia, which separates the subcutaneous tissue from the muscle. The reason it's important to understand the basic structure is because different skin and soft tissue infections will involve different layers of this, and it helps with understanding. So there are some common themes in skin and soft tissue infections. So many of them have the same predisposing factors. Typically, there may be some kind of skin breakdown or trauma, which sometimes might be very minimal. With that can lead to a retained foreign body at times, which serves as a nidus for infection. Lymphedema, venous stasis, and vascular insufficiency in and by themselves are quite important risk factors. Obesity is independently associated with recurrent infections. And then, of course, immunodeficiency is another big one. So we'll start off with the most superficial of these infections, starting off with folliculitis. So folliculitis is basically an infection or a pyoderma which is located within and around a hair follicle. It may be individual or multiple. And typically the way it presents is with a small erythematous papule or a pustule, and in the center of that is the hair follicle essentially. Most commonly, folliculitis is caused by bacterial infections, of which most commonly Staphylococcus aureus is implicated. However, other organisms have been isolated, including gram-negative such as Pseudomonas, and also fungal infections caused by Candida or Malassezia furfura. Now, there are non-infectious reasons for folliculitis as well, so it is important to keep that in mind as well, especially in people who have non-resolving or recurrent infections. Two examples of these are eosinophilic pustular folliculitis and amicrobial pustulosis. The image on your slide, you can see a typical example of folliculitis. Over here, you see multiple follicles being infected, and as can be observed over here, each follicle is individually infected. You can see that the hair, it's centered around the hair, and there's a surrounding kind of rim of erythema, or rim of erythema surrounding the pustule as well. Here's another example. The picture is a little grainy, but what is being shown over here is another example of folliculitis, specifically hot tub folliculitis. And these people, this is often caused by Pseudomonas, which can be present and colonize artificial kind of water bodies, typically like bathtubs or hot tubs and stuff. And what can differentiate this from other forms of folliculitis clinically is that there's usually a sharp demarcation. So till the level of the waterline, you can see folliculitis till the waterline, and above that, typically the skin is spared. So how about treatment? Now that we know what it looks like, typically just look if the infection is very localized, then just local measures may be sufficient, such as just cold compresses. For topical infections, again, topical antibacterials or antifungals such as mupirocin or chlorotrimazole may be enough. However, as seen in the previous picture, sometimes the infection may be more widespread, and sometimes it may even be more severe, and hence the need for systemic antibiotics. And that is dependent on the etiology. So, for example, if it's a hot tub folliculitis, you want something with pseudomonal activity. If it's not associated with that, you might want to just use, earlier generation cephalosporins or penicillins for that matter. In cases where the disease is severe or refractory, keeps on coming back, or it's not getting better, a biopsy may be warranted for culture as well as for pathology, because as I mentioned earlier, sometimes this can be secondary to a non-infectious etiology. Next, we move on to carbuncles, furuncles and carbuncles. So they are associated or similar to folliculitis. However, they are a little more extensive. So a furuncle is when there is a deep inflammatory nodule developing from a folliculitis, and essentially it is not just limited to the follicle itself. There is involvement of this surrounding soft tissue in addition to the follicle itself. Whereas a carbuncle, it is basically two or more furuncles that are coalesced together. And many times there may be sinuses between these furuncles, and so there are multiple furuncles together that are communicating with each other. Now, a typical risk factor is extensive perspiration and areas of friction. Basically, that's what usually predisposes to this and causes it. And the most common organisms for furuncles and carbuncles are Staphylococcus aureus. Typically, it's a pustular kind of an infection. However, in other instances, other bacteria may be implicated as well. Coagulase negative staphylococci, on rare occasions, even streptococci and gram negatives may be implicated too. So here's an example of each of them. So on the left side of your screen, you see a furuncle, whereas on the right side, you see a carbuncle, where you can see that there are multiple kind of pinpoint areas of pus, essentially, and it's a collection of multiple furuncles. The predisposing factors are very similar as described at the start of this presentation. So obesity, diabetes, immunocompromise, whether that be from some underlying condition or immunocompromising medications that are used, blood dyscrasias, etc. And typically treatment is multifold. One should provide moist heat, which leads to kind of maturation of these furuncles and carbuncles and leads to drainage. For larger lesions, you need incision and drainage to clear it up for source control. And then systemic antibiotics may or may not be used depending on the severity and location of the disease. So typically, if there is involvement of the face or if there's associated extensive cellulitis, you would like to add systemic antibiotics to that. Additionally, if there is severe disease, there's systemic illness, fever, chills, other systemic signs, hemodynamic compromise, which, to be fair, with furuncles and carbuncles is rare. But if you have systemic symptoms, then it is warranted to use systemic antibiotics. So when it comes to antimicrobials, one has to consider what basically is the etiologic agent. So as mentioned earlier, most commonly it is some kind of Staphylococcus species, typically Staphylococcus aureus. So based on that, you want to use antimicrobials that would be effective for it. Typically, you would especially in people who are otherwise not sick, you would start with a dicloxacillin or cephalexin. So oral options both, and so one can use this and see how they respond. There are instances where people may be allergic to beta-lactams, and hence in those situations, trimethoprim sulfa or clindamycin may be used. Sometimes when they have severe disease or systemic infection or systemic signs of infection, then that warrants the use of parenteral antibiotics, at least to begin with, and then one can de-escalate to orals. Options in these kind of patients include vancomycin, daptomycin, linezolid, or ceftaroline. And generally, one needs to engage in good hygienic practices, skin care, regular washing of clothes and dressings during this time. So next we move on to impetigo. That's another entity. So this is also infection of the superficial epidermis. It affects the subcorneal keratinocytes, and typically it starts as a vesicular lesion, and then once these erupt, fluid is released and it leads to what is typically described as a honey crust. Most commonly, it happens in kids. However, adults can have it as well. And it is usually associated with pruritus. And what's important to note is that it can be spread by scratching. So again, good hygienic practices should be encouraged. It is most common in hot and humid environments. However, not necessarily just those environments. It's just more common over there. And typically, it is caused by Streptococcus species, but Staph aureus is getting more common. And as you'll see later, when we identify this, at least to begin with, we give them antimicrobials that would cover both. So this is a typical example of impetigo. You can see what is described as a honey crust. So you can see this yellowish crust that is found in the perioral area of the skin. And of note, typically it is found on the face. Not exclusively, but typically. So how do we treat it? Local care is at the forefront. You remove the crust with soap and water, with sterile kind of dressings at times as well. And then if it's just a localized infection, then just topical therapy is sufficient. And that may include mupirocin, retapamilin, fusidic acid, etc. However, if it's more extensive, then systemic antimicrobials are warranted, and one can reach out for amoxicillin, cephalexin, cefadroxil, dicloxacillin, essentially early generation beta-lactams, if they are beta-lactam tolerant, essentially. In those who are allergic, then again, the options, as you'll see a theme over here, trimethoprim sulfa and clinda can be used. Previously, macrolides were used fairly often as well, but there is increasing resistance, so we typically do not use them as commonly now. This slide is quite important as well, not as seen as much currently, especially in the developed world, but there are complications that can arise from streptococcal impetigo, especially group A streptococcus. The two of these are post-streptococcal glomerulonephritis secondary to the nephritogenic strains. The other one is rheumatic fever, where there is involvement typically of the mitral valve, and left untreated can lead to destruction of this. Hence, the need to try to treat these infections as and when they are encountered, so as to not only treat the current active infection, but also to prevent the occurrence of these systemic eventualities that can happen. The next we'll move on to bullous impetigo. Similar to impetigo, it is infection of the epidermis. The difference being that instead of just vesicles developing, they form larger bullae, and they often rupture very quickly, leaving a brown crust rather than the typical honey crust. And there may be an erythematous kind of raw base as well. So this is caused by Staphylococcus aureus, ones which produce exfoliative toxins A and B. Here is an example of this, and as you can see, there are a few bullae that can be seen that are as of yet not ruptured, and then you can see evidence of a couple of bullae that have ruptured. So again, topical treatment one can start with, especially if it's localized. If not, then penicillinase-resistant penicillin such as dicloxacillin and amoxicillin clavulanic acid may be used. First generation cephalosporins such as cephalexin can also be employed. And in those that are allergic to beta-lactams and clindamycin, trimethoprim sulfa, linezolid, and rarely now erythromycin may be used as well. Excuse me. So next we move to eczema. It is similar to impetigo, however, it can and sometimes does actually go deep into deeper layers of the epidermis. It's common in children and older adults, so at extremes of age. And then the way it presents is like a punched out ulcer. And many a time there may be a greenish yellow crust and there may be surrounding violaceous margins or purplish discoloration. And the most commonly implicated pathogens are group A Streptococcus, Staphylococcus aureus, and Pseudomonas aeruginosa. However, there are multiple other organisms that can cause it as well. And treatment is very, very similar to impetigo. Typically, local treatment is sufficient. And here are two examples of this. So on the left, you'll see your typical eczema. You can see a punched out lesion in the center and a surrounding erythema that can be seen. On the right side is eczema gangrenosum, which is caused by Pseudomonas. And what you can see, the differentiating factor is that in the center, there's typically a dark greenish, sometimes blackish necrotic center that clinically may differentiate eczema gangrenosum from eczema. Erysipelas is the next one. So this is an infection that affects the epidermis and only the superficial dermis. The patient will often tell you that it developed very suddenly, it's very painful, it spread very quickly. So that's a typical presentation. And on exam, you'll see that the skin is quite indurated, it's red, tender, and it's the differentiating point or something to watch out for is that it is very well demarcated as opposed to cellulitis, which we're going to look at a little later as well. And these patients can often also have fever and leukocytosis, so they may have systemic signs. Here are a couple of examples. As you can see, it's quite bright red. And what you see is that there is a very clear demarcation. And similarly over here, you can see a very clear demarcation from the normal skin. So this differentiates it from cellulitis. Predisposing factors are similar to before, as discussed, but namely lymphedema and venous stasis are common in these people. And then immunocompromised, diabetes, alcohol abuse, those are commonly implicated as well. Typically, it's caused by Streptococcus species, but at times Staph aureus has also been isolated, especially in lesions that involve the face. And this is a clinical diagnosis, so one does not need really any kind of testing, imaging or otherwise for this. But academically speaking, biopsy cultures are only positive in about 20 to 30% of patients, and hence not necessary. So clinically, if it looks like erysipelas, it likely is erysipelas, and one should treat it like that. And then recurrence is common because typically the risk factors are the same, and this can happen again. So treatment involves elevation of extremities, and then based on the severity of disease, that can determine what kind of antimicrobials to use. So in mild and early cases, an oral penicillin or an intramuscular shot of procaine penicillin may be used. Clindamycin may also be used, and those are allergic. Sometimes macrolides could be used, but typically that's not your among your initial choice. But in penicillin allergic people, that could be employed if no other choices. Now, those who have more extensive involvement, they ought to be hospitalized and treated with parenteral antibiotics, typically with aqueous penicillin, a first generation cephalosporin, or either with a beta-lactam-beta-lactamase inhibitor combination. So next we shift gears into cellulitis. This also involves the epidermis and the dermis, but occasionally may also involve the deeper layers of this and also the subcutaneous tissue. And that explains the way it presents as opposed to erysipelas. So typically it's caused in an area where there may have been some previous trauma, or there has been a break in the skin or something similar. And these patients will also present with development of pain, tenderness, swelling, erythema, warmth. So typical signs of inflammation, they'll present with that. Now, the differentiating factor, as I alluded to a little earlier, from erysipelas is that the borders are typically not as well demarcated. And pathophysiologically, that is attributed to the fact that it does go a little deeper and it's easier for the infection to kind of diffusely kind of spread a little bit. And that leads to the clinical presentation that is observed. These people may sometimes have systemic symptoms as well. So definitely that needs to be inquired when seeing these people. So cellulitis is divided into purulent and non-purulent, and that is to clinically try to differentiate between what organism might be the etiologic agent, and hence to attempt to administer them the best possible treatment for that agent. So the agents that are typically seen are Streptococcus species and Staphylococcus aureus species. So there's a common theme that we're seeing with skin and soft tissue infections. Rarely, however, gram-negative rods may be implicated. Typically, this is in diabetic or immunocompromised people. And similar to erysipelas, recurrence is quite common. So the images over here show you the two varieties of cellulitis, and you can see typical signs of inflammation, at least by visual inspection. And then usually the erythema and all, there is a little more kind of, it's not as well demarcated. There is a little bit of it diffuses into the normal skin as well. So on the left, you see non-purulent cellulitis, and on the right, you can see purulent cellulitis. So you can see this area of, or this pocket of pus. So how do we treat it? Treatment is actually pretty similar to erysipelas. You want to elevate the affected extremity. You want to, if there is associated purulence, you want to use sterile and cool dressings to remove that for source control. If there's a large abscess, then incision and drainage is recommended. And then based on the kind of cellulitis you have, and hence the kind of bacteria that may be implicated, determines what kind of antibiotic you use. So if one sees purulent cellulitis, you would like to use something with Staphylococcus aureus coverage, ideally with MRSA coverage. If it's non-purulent, then you want to use a penicillinase-resistant beta-lactam so as to cover typically just streptococcal infection and some MSSA as well. For mild disease, you can treat it with oral antibiotics. With moderate and severe disease, they may need hospitalization and use of parenteral antibiotics, typically with MRSA coverage. So since these are the two common organisms that are implicated, I think it's important to present some options for treatment. So for Streptococcus, as mentioned before, first generation cephalosporins or penicillin antibiotics, aminopenicillins may be employed. If they have penicillin allergy, then trimethoprim sulfa or clindamycin could be used. And if Staph aureus coverage is sought, then if there is isolation of MSSA, you want to use oxacillin, nafcillin, cephalexin, cefazolin, clindamycin, etc. If there is suspicion for MRSA, then you want to have something with coverage for that. So vancomycin, daptomycin, clindamycin, doxycycline, trimethoprim sulfa, linezolid, these are some of the options that are at your disposal. So that was your basic run-of-the-mill cellulitis. Now, there are some special circumstances that need to be considered, and these are encountered fairly often, so I think it's important to know about them. Sometimes cellulitis may be associated with perioral lesions, it may be perirectal, it may be associated with decubitus ulcers, fistulas, or diabetic foot ulcers. And then in these instances, what needs to be on your mind is also that there may be some gram-negative implicated, sometimes an anaerobe may be implicated as well, and hence a combination of antibiotics should be used that not only covers your typical staph and strep, but also gram-negatives and anaerobes. So a typical example would be a beta-lactam with a beta-lactamase inhibitor, or one could use ceftriaxone or a fluoroquinolone in combination with a metronidazole. Or in severely ill people, you might go for carbapenems. Although I must say that, that should not be something that we reach out for to begin with. Then a special circumstance is that of human or animal bites, and typically amoxicillin, clavulanic acid, and ampicillin sulbactam is an excellent choice for these people. So switching gears to animal bites, this is a little bit of a special circumstance. So there are some basic principles of treatment, and then, with certain different animal bites, there are some deviations in terms of what antimicrobials you would like to use. So the general principles are: one needs wound care, you need irrigation and debridement, you want to get rid of any necrotic and dead tissue, and get rid of any visible infection that you see with that, essentially. So imaging ought to be done for fractures, number one, because that can happen with many animal bites, and also to get a baseline for osteomyelitis and to detect foreign bodies. So many animal bites may lead to osteomyelitis down the line. So you want to have a baseline image to see what their bone looks like before you actually have, before this actually sets in. And then in most animal bites, at least to begin with, it's not recommended to close the wound because of the fact that, there are typically anaerobic organisms involved, and wound closure that leads to a ripe environment for these anaerobic organisms to proliferate. So at the very least, to begin with, these wounds should not be closed. They should be cleansed and irrigated and debrided if needed, but closure should not be employed to begin with. And this is an instant whereby prophylactic antibiotics are actually recommended because of the high incidence of developing infection. And then from depending on patient to patient, they may need certain vaccines as well, and also depending on the incidence of infections that may be common in a particular geographical area, such as rabies. So talking a little bit about cat bites to begin with. So the kind of the anatomy of the teeth of cats is such that the wounds are typically very deep and penetrating. And that might not be visible on superficial infection. So if there is a cat bite, one ought to assume that, the wound is deeper than what it seems. And most of these get infected. That's just owing to the kind of flora that is present in a cat's mouth, and also owing to the fact that these bites are pretty deep. So they can be non-purulent or purulent, and they may or may not develop lymphangitis with it. There's also a possibility of abscess development too. So there's a couple of organisms that are typically associated and unique to cat bites. And these are Pasteurella maltacida as well as Bartonella henselae. So Pasteurella maltacida is an aerobic gram-negative rod, and almost all cats are colonized with these, and almost all of these bites cause infection, and hence these people need to be treated. Even if you initially do not see signs of infection, it is imperative to give them antibiotics to begin with. The good thing is that almost all Pastorella maltosida are sensitive to amoxicillin, so we have a great choice for that. The second pathogen that is implicated with cat bites is Bartonella henselae, and it typically causes cat scratch disease. It can cause regional lymphadenitis, and rarely, especially in immunocompromised people, it can lead to a more systemic infection. It can cause more distant involvement of lymph nodes and glands, and sometimes the spleen and liver. But usually, this is a self-limited infection, especially in immunocompetent people. And treatment of that is usually employed is azithromycin. However, clarithromycin, trimethoprim sulfa, ciprofloxacin, or rifampin may be used as well. Moving on to dog bite. So most of them actually do not get infected as opposed to bites with cats. And potential pathogens that are specific to dogs include Pasteurella canis and Capnocytophaga canemorsus. In some people, a specific population actually, i.e. splenectomized patients, they can develop overwhelming sepsis with Capnocytophaga infection. And hence, especially these people, they need to be treated aggressively to begin with. As with most bites, you can't really go wrong with a combination of a beta-lactam, beta-lactamase inhibitor, typically amoxicillin clavulanic acid or ampicillin sulbactam. However, um, piperacillin tazobactam, penicillin G, and clindamycin could be used as well. Next, we move on to rat bites. So rat bites typically are responsible for two different kinds of, or they have two different kinds of bacteria that can cause infection. So rat bites, they lead to what's called rat bite fever, and it typically presents with a rash. It may be maculopapular, it may be pustular, it may be petechial, and oftentimes this rash is also associated with a systemic or not a symmetric polyarthralgia. It may involve large or small joints. And it is also associated with a fever, as the condition implies, rat bite fever. And the two typical organisms that are implicated are Streptobacillus moniliformis as well as Spirillum minus. And they're typically treated with penicillin or doxycycline. And these people usually respond very well. Another special circumstance is people who are exposed to water. And also the nature of the water body is important as well in terms of what organisms may be implicated in these infections. So if you have kind of standing salt water, brackish water, kind of estuary water exposure, then one should be concerned about Vibrio vulnificus. This is an organism that is typically found in these kind of water bodies. And typically, in addition to what you would typically use for a skin and soft tissue infection, for example, cephalexin or penicillin, you would also want to use doxycycline because your typical antibiotics that you use for a skin and soft tissue infection, cellulitis, they do not have activity against Vibrio vulnificus. So you want to, in addition to that, add doxycycline as well. Another instance is if there's an abrasion to an infected animal, such as a pig or a fish, then these animals are carriers of erysipelathrix rhiziopathy. And these are also usually very sensitive, but it's important to be able to recognize these patients. So they usually respond to your typical run-of-the-mill antimicrobials that you would use for skin and soft tissue infections most of the time. However, if they are not responding, then a fluoroquinolone or clindamycin ought to be added to this regimen as well. And then finally, there is freshwater exposure. So these water bodies often carry an organism called Aeromonas hydrophila, and these are almost universally kind of sensitive to quinolones, typically ciprofloxacin. And hence this should be added to the regimen of your a typical skin and soft tissue infection. Here are examples of these. So you can see Vibrio vulnificus, what it usually presents as, which is pretty typical, and it should be recognized, is that it presents with hemorrhagic bullae, and surrounding that, you may see some erythema. And again, for all of these, really, the history is very important. So it is important to try to gather what kind of exposures they may have had. Next, we have an image of erysipelathrix rosopathy infection. And usually you'll see them on the extremities, typically the fingers. So usually it happens because these people, they may be working with animals, fish, etc. Typically it may be seen in people who catch fish or scale fish, and they may get a cut on their finger, and that eventually leads to the infection that is seen over here. Finally, you have Eromonas hydrophila. And these may also lead to blisters and bullae, but typically they're not hemorrhagic. And then you'll see your typical signs of inflammation. Again, it's very important to get a history with regards to the exposures, because that may be the major clue that is required to make a diagnosis. So next we'll switch gears to more deeper infections. So we'll start off with necrotizing fasciitis. So necrotizing fasciitis is an extensive infection. It is deep to the deep fascia, deep to the superficial fascia in the subcutaneous tissue down to the deep fascia. And it is typically differentiated into different types based on the pathologic organisms that may be implicated. So there are more, but typically type 1, 2, and 3. Type 1 is polymicrobial. Type 2 is monomicrobial and most commonly secondary to group A streptococcus. And type 3 is from marine gram-negative organisms such as Vibrio vulnificus. Predisposing factors usually involve a combination of trauma, diabetes, peripheral arterial disease, immunocompromised state, cirrhosis, alcoholism, IV drug use, etc. So it is an acute necrotizing infection, and it can affect any site of the body, but most commonly it involves the extremities. After the extremities, the typical site is the groin in the perineum region. And usually it may start with very minimal symptoms. It may start with a little bit of erythema, swelling, or warmth, but then it progresses very quickly. These people start developing severe pain. They may develop severe tenderness in the area that it first started at. And there is discoloration. Usually it develops kind of blue-gray discoloration from the initial red. And eventually these people start having breakdown of their skin as well, and they may develop bullae and cutaneous gangrene too. Left long enough untreated, there is death of nerves that supply the skin and soft tissue, and there is anesthesia of that area. And that typically is not a good sign. Left untreated again, there may be increased pressure inside the compartment, and this may lead to compartment syndrome and high morbidity and mortality. And these people are very sick. Usually when they present, they're extremely sick. They may have hemodynamic compromise, systemic symptoms. So it's very important to recognize these people as soon as possible. Here are a couple of examples, and these are actually examples of fairly advanced necrotizing fasciitis. As you can see that, the infection has kind of surfaced. There are bullae, there are signs of necrosis of the skin. And there's quite a lot of swelling as well, as you can see. So there may be some lab abnormalities as well. There may be quite severe leukocytosis. There may be fluid shifts in these people, and hence hyponatremia and azotemia may develop. And on surgery, gram stain findings may be either polymicrobial or monomicrobial, depending on the etiological agents. Now, I mentioned that there sometimes may be involvement of the perineum, and so Fournier gangrene is a special form of necrotizing fasciitis, and it involves the groin area. And because of how the skin and soft tissue, the anatomy of the skin and soft tissue that is structured over there, because the fascia is not as tight as in the rest of the body, there is a propensity to for the infection to spread very rapidly. And some of these areas are actually devoid of the deep fascia. So that definitely makes it more easy to spread. And typically, this is polymicrobial, typically seen in diabetic individuals. Now, necrotizing fasciitis is a clinical diagnosis, so one needs to have a very high clinical suspicions, and if one suspects it, one should be taken as soon as possible to surgery because of the high morbidity and the very high mortality that is associated with delay of surgery. And with many of these infections that you'll see in subsequent slides as well, these wounds should be left open because you want to have source control. You want the infection to kind of drain out. And many a time they require repeated debridements and hence the need for the wound to be left open. And then to begin with, it's impossible to say what organism is causing this infection. So you want to treat them as if they have a polymicrobial infection. So one should give them fairly broad spectrum antibiotics. And eventually, once one has culture data from surgery, one can de-escalate in the antimicrobial regimen. So we'll talk about a couple of these implicated organisms. So we're going into even more deeper infection now. So moving on from necrotizing fasciitis to myositis, essentially. So we'll start with group A, streptococcal necrotizing myositis. And like necrotizing fasciitis, it is an acute and severe illness. And these people typically present with septic shock. Manifestations are similar with the addition with additionally from necrotizing fasciitis because they have involvement of the muscle. They will have rigidity and they have swelling of the affected muscles. They may have intense pain in that area. And sometimes even if the infection starts deeper, then one may not initially see any signs of overlying skin infection. However, if left untreated, this infection surfaces and it doesn't start affecting the more superficial layers. Sometimes there will be bacteremia associated with that, and these people can develop compartment syndrome very quickly. In terms of laboratory findings, it's similar to neck fash. There's a lot of leukocytosis, typically very high numbers. And because of the hemodynamic instability, there may be fluid shifts again. You can see signs with regards to that, such as elevated BUN creatinine. And then specific to myositis, you will also see elevated creatine phosphokinase because there is breakdown of the muscle itself. Imaging can sometimes help, whether that be ultrasound, CT, or MRI. However, this is a clinical diagnosis as well. And if this is suspected, if a clinical diagnosis of necrotizing myositis is suspected, then imaging should not delay surgical intervention. These people should be taken to surgery. And treatment, similar to before, prompt and extensive surgery. In addition to this, you want to give them high-dose antibiotics. If one knows for a fact that this is streptococcus infection, group A streptococcus infection, then high-dose penicillin G and clindamycin. However, initially people usually do not know, and hence broad-spectrum antimicrobials should be given. Here are a couple of examples of group A streptococcal necrotizing myositis, and you can see there's kind of a dusky necrotic appearance of the muscle at the base, and then they do require repeat debridement, so you want to leave them open. All right, next we have clostridial myonecrosis, so also known as gas gangrene. This is also an acute and quite rapidly progressive infection that involves muscles, and it's implicated with high morbidity and high mortality. Typically, it's caused by Clostridium perfringens. However, other Clostridial species may be involved as well. And, typically this infection is in the extremities. However, other areas may be involved. such as bowel and biliary tree. The female urogenital system may be sometimes involved as well with non-sterile abortions and deliveries and stuff like that. And this infection is associated with infection with Clostridial spores. So common scenarios include traumatic injuries, penetrating injuries during wars, bowel and biliary tract surgery, septic abortions, and arterial insufficiency. Predisposing factors, again, are they're the typical common predisposing factors that were mentioned in previous infections as well. So namely, diabetes, peripheral arterial disease, the presence of devitalized tissue after an injury, the presence of a foreign body, neutropenia, intestinal tract abnormalities, etc. So the way it presents is very similar to group A strep myonecrosis. However, the difference being that this may be even more rapid. Sometimes these people may develop shock and myonecrosis within the first 4 to 5 hours of infection. However, the time period is varied and maybe a couple of days as well. Again, there's rapid development of pain, which is usually worse than what you are able to actually see and visualize. There may be some crepitus because of formation of gas by these anaerobic organisms. There may be tense edema, there may be blebs. It's typically associated with a very foul smell and with dark fluid collections as well. Initially, the skin may start appearing as bronze colored. However, it typically progresses to frank necrosis as well. And these people, as I mentioned, are very sick even to begin with. So when they come to you, they may look systemically, they may look sicker than what the local signs of infections are. And they have signs of that as well, such as a fever. So in example of Clostridial myonecrosis, as you can see, there is a dark discoloration to the skin and muscles, and very extensive. And there is very high morbidity and mortality, even with implementation of urgent treatment. So lab abnormalities, typically you'll see signs from fluid shift, such as a decreased hematocrit. Initially, there is usually leukocytosis. And then from the surgical specimen, you may see gram-positive bacilli with blunt ends. And typically, you won't see many neutrophils. Treatment, similar to before, is with emergent surgical exploration and extensive debridement, and treatment with high-dose penicillin G and clindamycin. So that brings us to a close. In summary, one needs to have a basic understanding of the anatomy and the microbiologic etiology. Location and severity of disease guides initial treatment. One ought to think about epidemiological risk factors, as that can be a major clue as to what the organism is that is implicated in the infection. And then fulminant infection can develop very rapidly. So one should have a very high clinical suspicion. And if so, get your surgical colleagues on board early so as to prevent the morbidity and mortality that is associated with these infections. With that, I'll conclude the presentation, but I will open the floor to any questions.
Thank you so much, Dr. Khan, for that excellent discussion. We'll start by opening up questioning to Dr. Chinda and colleagues.
I have a question.
Go ahead, Dr. Rodriguez.
Yeah. Thank you so much for a great summary. This was very well done. So I have a question about, just for practical purposes, what would you recommend for antibiotic choice if a patient has a dog bite or a cat bite and he's allergic to penicillin?
That's a fantastic question, Dr. Rodriguez, and one encounters this fairly commonly. So if they're allergic and so the question is if one is allergic and they encounter a cat or a dog bite. So typically your go-to after your beta-lactamase inhibitor is a combination. Typically, it's a combination of clindamycin with either trimethoprim sulfamethoxazole or with some kind of a quinolone. And for most people, that is a sufficient choice. That gives you enough kind of a wiggle room that even if they have other intolerances, you would cover the typical organisms that are implicated in these infections.
Great, thank you so much.
You're welcome.
Okay, good afternoon, Dr. Khan. This is Dr. Chinda from Bingo in Cameroon. We would like to start by thanking you for really an excellent talk, and most importantly, for highlighting the importance of identifying potential exposure, as they could significantly help tailor the antibiotic for the patient. We had a couple of questions from this side, though. We were wondering, because we often get to manage a lot of immunocompromised patients, either from HIV or neutropenic patients following chemotherapy. Now, we would like to find out, how would you recommend we approach these patients? Now, would you upfront recommend a more aggressive approach regardless of the severity of the initial symptoms? Or should we just go ahead and manage it similarly to those who are not immunocompromised? And the second question was about fungal skin and soft tissue infections. Now, the talk primarily focused on bacterial etiologies, but how common are these, and should we be concerned? And if yes, in what population?
Thank you for the excellent questions, Dr. Chinda. So I'll start with the first one. So the first question is, people who are immunocompromised from any reason, whether that be HIV or chemotherapy or some other immunocompromising medications, they be treated any, or to begin with, should they be treated any differently in terms of antimicrobial options? So once you have a diagnosis, you don't necessarily need to treat them with any different antibiotics. They can be treated with similar antibiotics as that would be used for people that are not immunocompromised. I will caveat that with one thing though. Many of these people may have previous culture data. So if previously these people have had some kind of resistant organisms isolated, if they've had, let's say, Pseudomonas isolated or some kind of MDR organism isolated, then to begin with, at least, one ought to use antibiotics that would cover that. And once, if these are patients in whom one can obtain a culture and we can get a culture, if that gives us reason to de-escalate, then we can. As far as the second question goes, is with regards to how frequently one sees fungal infections in skin and soft tissue infections. So I will talk about that in relative terms. Relative to bacterial infection, they are rare. So we don't see them as often. Typically, when you do see them, you will see them in people who are immunocompromised. The kind of organisms that are isolated, again, they vary on the immune status as well. The organisms that could be isolated at times could be, as I said, Malassezia, sometimes Candida. In addition to that, Fusarium is something that can sometimes be seen. You can see some of the agents of kind of the zygomycetes or mucormycosis, those kind of things. You can see those organisms as well. But as I said, it's not very common. Fungal infections typically do not cause as much skin and soft tissue infections as do bacteria.
Well, thank you very much, Dr. Khan. That answers it very well. Thank you.
You're welcome.